Good afternoon and welcome to the Distinguished Interprofessional Education Lecture Series presented by the Center for Oral Disease Prevention and Population Health Research. We call it the 7 Things series in short. I am Tamana Tiwari. I'm the Associate Director of COPPR. We have 2 really great speakers today who will be talking about pediatric primary care. A few housekeeping things. If you are looking for dental CE, Dr. Callanan will be dropping a link in the chat, so please complete that. Click the link, complete the survey, and then you can get your CEs. Also, our next 7 Things event will be held in the fall, and Dr. Susan Somerset and Dr. Liza Claus from the School of Pharmacy will be discussing clinical pharmacy and dentistry. Today, we have 2 speakers, Dr. Katherine Chin and Denise Ogden. Katherine Chin has served as the Clinical Medical Director for the Children's Hospital Colorado since 2011 and is currently the interim chair of Department of Pediatric Dentistry. She's also a member of the Colorado Multiple Institutional Review Board and has served on the Colorado State Dental Board Anesthesia Committee. Dr. Chin received her dental degree and her Master's of Science in Oral Biology and Pediatric Dental Specialty Certificate at UCLA. And Dr. Chin has completed a fellowship at the NIDCR as well. Ms. Denise Ogden has been a member of the faculty at the Children Health Associate and Physician's Assistant program since 2018. She's also a senior instructor with the Department of Family Medicine and practices in Lone Tree at the primary care. Prior to this position, she was a member of the faculty at the Swedish Medical Family Medicine Residency Program for 22 years. In addition, Denise has served as the master trainer with Cavity Free at 3 through the Colorado Department of Public Health and Environment for several years. And she completed her training at the University of Colorado CHAPA program and remains committed to excellence in primary care education. So welcome both. Dr. Chin is going to be our first presenter. So take away, Dr. Chin.
Hello, thank you so much, Dr. Tiwari. And I'm so happy to be here because this is a really exciting time in oral health, because when I came to this campus, I realized how collaborative it is. And I love being at the School of Dental Medicine and on the Anschutz campus and also at Children's Hospital, because I think that this is a time when we are really collaborative. And I've seen that my partners in the healthcare professions are really open to learning about oral health and wanting to incorporate it into their practices. So I thank all of you for being here and for listening to the 7 things that I think that dentists wish that our healthcare providers in the medical areas wish they could share. And I wanted to start off with looking at what the public's opinion of going to the dentist is. And while it may be surprising to all of us, that patients and parents generally are not super excited about taking their young infant to the dentist, because they're thinking about the dentist as, oh, I'm going to go, I'm going to hear these drills, I'm going to have a filling done, and I'm afraid to go. Do I really want to take my child in for that? And so that's really a lot of what the public thinks about going to the dentist. So we want to, as dentists, to also prevent those surgical interventions, the fillings, the crowns, the extractions. And so we'd like to do that by really hitting the prevention strong, because caries is a preventable disease in most instances. And we really want to partner with the medical care providers, because you all see the patients many more times than we do before the age 1 dental visit. So the American Academy of Pediatrics, the American Dental Association, and the American Academy of Pediatric Dentistry have all recommended that the first dental visit for infants be by age 1. And we do a number of things during those appointments, but I really wanted to highlight that these young children actually are in the healthcare providers' practices much earlier, as you know, starting with day one. So Doctors Clark and Braun reported the AAPD's findings that only 2% of kids see the dentist at age 1 versus 80%, 87% of those children, they would see their PCP by the age of 1. And by the age of 1, 10% of kids already had caries. So we are starting later than all of you. And so we would love to have help in terms of education for this young population. What do we do at the age 1 dental visit? So we do a lot of caries prevention education. The main thing that I want to drive home with parents is that we want to prevent the habit of going to bed while sleeping with a bottle of formula, going to bed while breastfeeding, because children fall asleep and then the milk sits on the teeth all night or for hours at a time, and that is cariogenic. So if that habit can be prevented before it even starts, it's so much easier. Our little infants are so intelligent that once they get into that habit, it's so hard for parents to break. And so if they don't start it at all, it's really much better for the child. Cleaning the teeth after a feeding is the ideal way to go. So we also talk about oral hygiene instruction, brushing twice a day with a fluoride toothpaste with a small grain-sized, rice-sized grain of rice amount of toothpaste smeared into the brush is beneficial for these young patients, and then to brush those teeth twice a day. Once their teeth start to touch together, they need to floss. The other thing that we do at the appointments is the fluoride application, and that's to prevent caries and to help mineralize any early carious lesions. And then finally, we do safety education to prevent oral facial trauma. So again, these things can also be done with your caries risk assessment in the healthcare provider's office, and fluoride application can also be done. And so we really thank you for providing that for these patients. And then early referral to the dentist would be great as well. As a subset of that prevention, I wanted to also talk about nutrition. And nutrition is part of the caries risk scale. And so if I could have the next slide, that would be great. You can see here that we have protective factors, and we also have pathologic factors and disease indicators. So I want to talk about the pathologic factors, and that's the cariogenic bacteria, the 3 snacks a day. And we have greater caries risk when we have more frequency and longer duration of fermentable carbohydrates on the teeth. And so that could mean sugary snacks, sugary beverages. And when kids have those things more than 3 times a day, that's when they have a greater risk of caries. And I wanted to also mention that we have a lot of patients who have failure to thrive, and they've been recommended to use high-calorie nutritional supplements like Pediatric and Boost. And those are great to help with the nutrition for the children. And we just want to partner with all of you with that recommendation to make sure that kids are brushing or rinsing after they have that Pediatric or Boost. And then also just to sit down and drink that serving in one sitting rather than grazing throughout the day with a sippy cup. Because again, remember, increased frequency and the increased duration is associated with more caries. And so if children have a sippy cup of Pediatric and they do a puzzle, they take a sip, and then they will run around, and then they'll take another sip, and they're just grazing on it throughout the day, it doesn't form great habits in terms of feeding. And we would prefer that they just have it all at one time, like sit down for lunch at a table, let's sit in the high chair, let's have your Pediatric, and then move on throughout the day and then go ahead and play. And so that they're not grazing throughout the day. The other thing that I wanted to talk about again is just unsupervised feeding during sleep. This is something that is really common with our patients, and they will be under the habit of going to bed when they are sleeping with a bottle, because it's an easy way to get kids to go to sleep. And so we really work with the families to say that, good sleep hygiene really does not involve putting your child to sleep with a bottle. And so if that could be broken early on, that would be extremely helpful for the kids and really prevent the needs for surgical intervention. Thank you. So I want to just talk about the dental visit and some of the things that happen. And when we're preparing for the appointment, we have a number of patients with complex medical histories that need pre-medication before their dental appointments. And so I just wanted to share some of the things that we look at when we have a patient with complex medical history. And those might be patients with congenital heart conditions. Those patients do need antibiotics before their dental treatment. And we would love to know in advance who those patients are so that we can get their prescription to them ahead of time so that they can have a smooth appointment. And so sometimes patients will write on their medical history that they have a heart murmur, but they don't know what kind it is. They don't know if they need antibiotics. And so those are times when we would consult with our healthcare provider professionals and our PCPs to find out whether or not the patient needs those antibiotics. We need antibiotics before most dental treatments. So not for an exam, but we do need it for the cleaning because we are manipulating the gingiva. And if we're doing any procedures, we might be manipulating the gingiva and the end of the tooth or the apex of the tooth. So if parents know the type of murmur that they have and whether they have need the antibiotics before dental treatment, that's extremely helpful because again, it helps us to plan better for the appointment. As far as benign murmurs, many patients have benign murmurs and they do not need antibiotics, as you know. So those, if the patients know they have an innocent murmur or functional or a Still's murmur, that's really helpful because when they communicate that to us, then we can just say, okay, we can go ahead and see without the antibiotics. And patients who have organ transplants, some of those patients also require antibiotic prophylaxis. And in my experience, most of them do, but not all of them. And so that's why it's a question in the dentist's mind. Does this patient need antibiotics or not? Our primary goal is to keep patients safe, and we wouldn't want dental cleaning to create systemic infection. Bleeding disorders or patients who are anticoagulated for other conditions may require pre-treatment from before the cleanings, and they may require things like medication like Amicar or transfusions before cleanings and extractions. And I know it sounds like it might be extreme to look at these measures before doing a cleaning, but I do want to highlight that sometimes patients in these populations with complex medical disorders, their oral hygiene really needs some work. And if patients have a lot of plaque on their teeth, they have really irritated gingiva and it's very inflamed from that plaque, and the gingiva bleeds very easily. So it's different from a patient who has good oral hygiene and they don't have all the bleeding that these patients who have the need for better oral hygiene do. And I think that sometimes patients with complex medical conditions, parents can be, they have to prioritize what is important. And so a lot of parents will say to me things like, I have so many doctor's appointments for my child. They have so many blood draws, and brushing teeth is just low on our priority list because there's only so many things that I can nag about. And so sometimes we are indulgent and we'll give a lot of sugary snacks and we will let the oral hygiene go simply because they have so many other things going on in their lives that we need to do to keep them alive. And so we as dentists completely understand that. And so we just want to work with them to help them have the best oral hygiene and the best oral health that they can. So my ask to all of the healthcare providers is to, if you can, remind patients who would fall into these categories, who need antibiotics or any kind of pre-treatment, to let them know before dental appointments, they should let their dentist know that they need medication. And then now that we have shared notes, it's awesome because I can see many of your notes. And if you document the medication requirement in your note, that would be extremely helpful and would really prevent me from having to take your time from providing another consultation request. Okay, thanks. And then we're going to move on to behavioral strategies. So what happens at the dental appointment? So we have, as I was saying, not everybody loves to go to the dentist. And so we have a lot of behavior guidance strategies to help our patients to accept dental treatment and to accept exams. And we have basic behavior guidance techniques. They're here on the left. And those are things that are really pretty verbally oriented. It's tell, show, do. That's self-explanatory. We do a lot of distraction, positive reinforcement. It's a lot of entertaining and distracting the child so that we can get a good exam done. And then we also have desensitization, where we will take extra time at appointments to show parents, okay, and patients, here's the light. It's very bright. Do you want to touch the light? Here's my mirror. It looks like a spoon and it's very smooth and curved. And so we'll show all of these instruments to the patients so that it's not as scary. I completely understand that a patient who comes in and they're asked to sit in a chair, they lay back flat, they have a big shining light in their eyes, and they're asked to open their mouths while a stranger looks into their mouth. That can be pretty intimidating. And so we want to make the appointment as friendly as possible. If we need to do procedures, nitrous oxide and local anesthetic are tools that we use to help with anxiety and patient comfort. If patients are not responding well to basic behavior guidance, then we move on to advanced behavior guidance. And for short procedures like extractions on an urgent basis, we may use medical immobilization. And that's with a papoose, it's with restraints. And that, again, is to keep the patient safe and only for short procedures. The next consideration is oral moderate sedation, which many dentists do in their offices. And those patients are awake, they're conscious, they're easily arousable, their reflexes are intact. And because it's oral moderate sedation, those medications are not titratable. So it's not 100% effective. And we in our clinic and many other pediatric dental clinics use meperidine or midazolam or some combination of both of those medications. And then we will do procedures for the patients. And the working time is around 30 to 45 minutes. So we can do a few procedures for patients under that setting. And then for the patients who have a lot of treatment needs or for whom moderate sedation, more than moderate sedation is needed to treat anxiety, we have general anesthesia in the hospital. And we, in the pediatric program here at Children's, we will go to the main Anschutz campus hospital or to the Broomfield Hospital. But I wanted to also mention that pediatric dentists and some general dentists in Colorado are using dental and medical anesthesiologists in their offices. So those anesthesiologists will come in to a private office and perform general anesthesia techniques so that the dentist can do full mouth rehabilitation. Okay. Part of our practice also, and many other practices nationwide, include children with special healthcare needs. And this is a really special population that we love to see. And we have a special clinic, and the School of Dental Medicine also has a special clinic for the patients with these special healthcare needs. And the conditions are there's a multitude of conditions that we treat. I just highlighted a few here and to let you know what the types of patients that we're working with. Some of them also have a lot of medical complexity, like the congenital heart disease that I already talked about. But these patients with developmental delay or autism, cerebral palsy, many of them have oral aversions and sensory processing disorders. And so some of them have G-tubes, some of them may have swallowing disorders. And so we want to really have a friendly place for these children to come where we can spend extra time looking in at their dentition and helping them with their oral health needs. And so again, we provide desensitization. We have medical play. We work with child life specialists who are wonderful, and they have a very friendly play set of equipment where we have models of teeth that are large and the children can touch them and play with them. And then we have big mirrors, big dental instruments that detect cavities so they can feel them. We have the spin brushes, and the children will feel the vibration. And these are really helpful to desensitize the patient. And we use visual schedules as well, which you can see on this clipboard. We have each step of the dental visit here on this clipboard, and we move the cards after the child has accomplished each step. So first we'll just show them, okay, first we want you to get in the chair. And sometimes, depending on the patient, that can take a little coaxing. Sometimes that's the only thing that we accomplish during our visit is getting in the chair. And so that may seem small, but for this patient, it's a big victory. So we just take our time getting into the chair, putting on the eye protection, which are the sunglasses, opening your mouth wide, showing them the mirror, and then the instruments to clean. And so it's a big sense of accomplishment when we can move those cards over. And then the patients, especially those who are not verbal, can visually see the steps of the appointment and look to the next level. There are some in our clinic who also use sign language, which is really helpful for our patients who are nonverbal. Excuse me. And we also have weighted blankets and medical mobilization. There are some patients with autism and other conditions who feel much more secure and comfortable if they're in a wrap with medical mobilization. And then we're able to provide the exams in that regard. And then general anesthesia is performed when these other options are unsuccessful, or if the patients have treatment needs and surgical interventions that we cannot do safely while the patient's awake. Okay, excuse me. The next thing I wanted to talk about is dental infection. And so odontogenic infection is something that is unfortunately a very real part of dentistry for children. And the main thing that I wanted to talk about as far as highlighting what we do is our goal is to treat the source of infection whenever a child has a dental infection. And the treatment is extraction or is root canal, which removes the pulp of the tooth. The pulp is that neurovascular tissue that lives inside the tooth. And antibiotics are an adjunct to the treatment. So there are a few things that can happen with odontogenic infection. When that pulp becomes infected, it drains through the end of the root, and it can present as one of two things. It could either be draining as a gum boil, and this is not an urgent situation. It comes through the attached gingiva of around the tooth, and it does not cause facial swelling. So those are not urgent. But when the drainage is trapped under the facial muscles, that's when the patients get facial cellulitis, and this is an urgent condition. I have some diagrams just to show you, illustrate to you what I'm talking about. So if we could have the next slide, that would be great. Thank you. So at the top left, you can see that when caries occurs, it starts through the outer surface of the tooth, and then at a microscopic level, the bacteria can infect the nerve of the tooth when that cavity is very deep. So when you have the deep caries, the pulp of the tooth becomes infected, and it's very painful because the tooth cannot expand. It's hard tissue. And so the drainage the only way that it can come out is through the apex of the tooth. Most drainage does not come out through the cavity because, again, it's microscopic, and the microscopic invasion of that pulp with bacteria. So most of the drainage is going to go out the end of the tooth. And at the bottom left, you can see if that drainage occurs above the muscle attachments, we'll get the gum boils, which is here on the upper right. And that's not the emergency. And then down at the bottom, you can see that this child has a facial cellulitis. And this is where the drainage is draining underneath the muscle attachment. And so this is an emergency. These types of infections progress very fast in children. And we want to monitor them very carefully for systemic infection and then treat the source of infection by either extracting the tooth or performing a root canal treatment. I will say that extracting teeth is a more definitive solution than root canal treatment. And typically this is what we will do in the primary dentition. Okay, next, thank you. Lastly, I wanted to talk about avulsion treatment. And this is where patients have a tooth knocked out. And we wanted to tell you about reimplantation of the permanent teeth within 15 minutes. This is where the prognosis is best, is if that tooth gets knocked out and it's put back into the socket within 15 minutes. We're not reimplanting primary teeth, just permanent teeth. But so if that happens, it's best if patients can just put the tooth back in themselves and then go immediately to the dentist. If for some reason a patient comes in with other injuries and shows up at your office, I wanted to give you this information as well. Relative contraindications to reimplantation are if the patient's immunocompromised and that patient is going to become systemically ill from having a foreign body placed back into the socket, congenital heart disease, uncontrolled seizures simply because they may knock the tooth out again, and a patient that has sensory disorders and could not tolerate a wire splint. It does feel like braces when we put that wire splint on. And then if the tooth has been out for more than 60 minutes, generally we have a long conversation with parents about whether or not we should put that tooth in because the follow-up is more complicated. After that tooth is placed in the socket, they should bite on a washcloth and then see their dentist immediately. Teeth that are out of the mouth for more than 15 minutes, they have a more compromised tooth because the periodontal ligament cells that live on the surface of the root are compromised. And so there may be some fusion of the bone that can happen with that tooth. And so they would require more dental appointments. If for some reason reimplantation is not possible, the best storage solutions are Biospan, Save a Tooth, which is Hank's balanced salt solution, and cold milk. Second best are saline and saliva if you don't have those things. And then this photo here just shows you the Save a Tooth kit. And it's really awesome because it has this Hank's balanced salt solution in the cup. You place the tooth inside this basket, it soaks, and then when you're ready to take the tooth out, you just pull out the basket and you don't have to manipulate the root of the tooth because, again, that's the sensitive area where we need to prolong the life of the cells. And then we can rinse it off and then put the tooth back into the socket. So again, if you can reimplant the tooth within 15 minutes, it's great. Rinse it off no more than 10 seconds under cold running water and then put it back in the socket. Okay. Thank you so much. I would love to turn the presentation over to Denise because she's going to talk about the things that she would love for the dentist to know.
Good afternoon. Thank you, Katherine. And thank you to Mana and Seven Things for the invitation to participate this afternoon. It's always a pleasure and an honor to be able to participate in these interprofessional events. So my list of 7 things today includes the following. Many of these I included to one, give an update on where we are in 2023, and number 2, to underscore the importance of early identification and the importance of the interprofessional team in actually screening for these issues and then referring for appropriate evaluation. So I'm going to start today with obesity. the increasing problem that we have with obesity. And I started when I developed these slides to say the growing problem, but that sounded too much like a pun. And I certainly didn't want to sound facetious, because obesity is a major problem in our pediatric population. Currently, we're at about 20% of our children and adolescents are obese. So numerically, that works out to about 14 million children across the US. Now, it always hasn't been this way, of course. In 1963, actually, the number of obese children in our population was less than 5%. We know that epidemiologic models today estimate that if current trends continue, our children who are currently 2 through 19, by the year 2050, 57% of them will be obese. So significant problem. As it's such a big problem, hot off the press, you have a link there to one of the newest guidelines put out by American Academy of Pediatrics. Is their clinical practice guideline for the evaluation and treatment of children and adolescents with obesity. This is their first ever, and it actually is full of great information. One of the things that we know that BMI still continues to be the best tool that we have, both for screening and diagnostics. Certainly always not perfect, but it is used in children to help to identify those who are overweight and obese. Different from BMI in adults is that, of course, kids are growing. So their BMI varies with weight and sex. So children who have a BMI greater or equal to the 85th percentile to the 95th percentile are considered to be overweight. Above the 95th percentile are considered to be obese. And unfortunately, as in adulthood, we now have a severe obesity category. And even within that, we now have class 1, class 2, and class 3 obesity. Why do we worry about obesity? We know that obesity certainly carries long-term and escalating problems. We're seeing things like dyslipidemia, problems with cholesterol levels in kids as early as 2, hypertension in kids as early as 3, and unfortunately, an increase in non-alcoholic fatty liver disease in kids. So important to identify, screen, and get these kids into some sort of treatment as soon as possible. One of the messages that the AAP guidelines, I think they do a nice job of talking about how to bring this up with families and kiddos. And one of the things that's emphasized is the use of non-stigmatizing conversations regarding weight. So before jumping into a conversation about a child's weight, actually asking the child and or parent for permission to discuss their BMI or to discuss their weight. Also using person-first language. So we have children with obesity rather than obese children, and certainly using a more neutral type of language to talk with kids and their parents. So using terms such as unhealthy weight or a child who is gaining too much weight for their age are considered to be more neutral. Number 2, sleep apnea, as we know, unfortunately, and this is a related topic, is not just for adults. We know that approximately 20% of our children now also have obstructive sleep apnea. This is most common in the 2 to 6-year-olds, as one of the major risk factors certainly is adenotonsillar hypertrophy. However, it's not limited to that age range, and we see a number of adolescents with obesity, up to 50% actually also have sleep apnea. The third group of children who are at increased risks are those who have craniofacial abnormalities. So those who have medical, dental, neurologic reasons that their upper airway size is diminished, or they have an increased collapsibility of the upper airway, they also are at increased risk. Now we know, like so many other chronic diseases, that in sleep apnea, early diagnosis certainly can help decrease morbidity. However, diagnosis for kids of sleep apnea is often delayed. So what are some of the symptoms that we look for? As my colleagues in dentistry know, habitual or loud snoring is certainly the number 1 symptom. And we certainly worry about kids who have loud snoring 3 or more nights during the week. Any child also who has witnessed pauses in breathing, is a mouth breather, whose parents report potentially they have excessive sweating during sleep, should be screened and potentially gone through diagnostic testing for sleep apnea. Sleepwalking and enuresis or bedwetting also can be risk factors. Moving on to number 3, as Dr. Chin talked about, developmental disabilities affects not only behavior and development, also oral health and some medical health. And the one developmental disorder that I wanted to just focus on today is autism. And autism is back in the news, back in the literature a little bit more in 2023, partially because we're seeing new numbers. So a new surveillance survey through the CDC just published in March of this year now estimates that the prevalence of autism is up to as high as 1 in 36 for kids of 8 years of age. Now, how does this compare to the past? In 2021, that number was 1 in 44, and in 2006, that number was 1 in 110. Now, why the increase? Most sources agree that the increase is happening because we're getting better actually at diagnosis of autism spectrum disorder. So what really is autism spectrum disorder? It's that spectrum of neurodevelopmental disorders that are broadly really defined by deficits in number 1, social communication. So these kiddos have difficulty recognizing that other humans have a social communicative purpose. Along with that, these kids also have patterns of restricted or repetitive behaviors. It is a collection of related disorders having differing manifestations, which is what makes diagnosis so difficult. There's no simple test for autism. And the other thing that makes things difficult is that autism often can occur in collaboration or in the same space as other developmental disorders. Etiology for autism is really very mixed, multifactorial. In fact, I see some sources that say so multifactorial, we may never completely unravel it. But autism, like so many other things, we know early diagnosis and treatment is absolutely the key for full potential to modulate health concerns, modulate dental concerns. And diagnosis should be made by a comprehensive multidisciplinary evaluation. I included a recent article in JAMA that I think gives a nice review of autism spectrum disorder. But certainly all of us on the interprofessional team can help to screen for autism spectrum disorders. Many of these symptoms, characteristics will appear by about 9 months of age. And it is certainly the hope that we can identify and diagnose autism spectrum disorders by age 2. However, statistics really show us at this point, it's often age 4 or after. So watching for things like kiddos who have previously were developing speech, were babbling, having social skills, and then they begin to lose those. As I said, these children lose the ability to identify other humans as communicative partners, so they prefer to be in solitude. They often don't make good eye contact. They can't understand other people's feelings. We see delayed language, kids who may repeat an entire commercial, but can't answer a direct question. They often will have things like resistance, and I know my dental colleagues know this, resistance to minor changes in their routine or surroundings, which makes any office, like a medical office, a dental office, a little more scary to them. The repetitive behaviors like clapping, rocking, spinning can also be a good clue. And then parents may report these unusual and intense reactions to sound, smells, tastes, which gives them difficulty, certainly, in eating. All right, next, abuse, neglect, and bullying. Not unfortunately uncommon and not unknown to any of us as pediatric providers. But I think this is a time that it always merits a reminder in the importance of the interprofessional team in having awareness, vigilance in screening for maltreatment of kids. CDC says now in 2023, about 1 in 7 children are abused and neglected each year. In 2020, about 1,750 children died of abuse and neglect. We know that craniofacial head and neck injuries are very, very common. So one of the things that we see in healthcare, one of the things that is seen often, I'm sure, in dentistry, and it's really thought that the oral cavity is likely a focus of abuse, probably a lot because of its significance with communication and nutrition. Other areas, however, that unfortunately we're having to focus on a little bit more are things like bullying. The numbers look approximately 30% of children in 6th to 10th grade report that they either have been bullied or have bullied others. And we know certainly that children with orofacial or dental abnormalities, including malocclusion, are often more frequently subjected to bullying. And that places them at significant risk down the road of serious psychological consequences. Unfortunately, the other thing that we have to think about is human trafficking. That's becoming more and more an issue and becoming more in the light. The precise numbers, obviously very difficult for obvious reasons to identify, but it's estimated that greater than 100,000 children each year are victims of prostitution and human trafficking. Now, while many of these kids stay off the health grid, numbers actually do indicate that approximately 25% of them show up needing health care, needing dental care. In fact, over 50% often complain of tooth pain or loss. So vigilant awareness, knowledge, and screening, very critical for early identification. So I'm switching gears just a little bit for the next topic, which is Ankyloglossia. And this was an interesting topic. I dove into the literature just a little bit because when I trained, which has been several years ago now, this was a little bit nebulous. Weren't sure what the definition was, weren't sure really what to do with it. Everybody seemed to have a little bit different approach. So Ankyloglossia, or tongue tie, as you know, congenital anomaly in which that inferior surface of the tongue is tethered to the floor of the mouth by a shortened frenula restricting the motion of the tongue, is not uncommon. There are still multiple different definitions, so the prevalence really varies from somewhere between 1% and 10%. We do think it happens a little more frequently in male children. Still lots of variation in opinion regarding the clinical significance, but we are seeing increases in rates in diagnosis and referral, so I thought it was worth just a couple of comments. So traditionally, the concerns in Ankyloglossia have been, will these children have difficulty breastfeeding? Does that restriction in tongue movement affect their ability to develop sounds? Does it affect their speech development? And then will there be a difficulty for these kids in the ability to perform mechanical or social skills as they get older? You know, licking your lips, cleaning your teeth, and even there was some concern about kissing. So in order to take a look at this, the American Academy of Otolaryngology Head and Neck Surgery convened an expert panel of pediatric otolaryngologists just recently and took a look at the evidence. They came up with a distilled expert opinion and clinical consensus statement to help clarify a little bit for the rest of us information on diagnosis, management, and treatment. Their statements, the article here that contains a full accounting of their statements, you can look that up. But some of the statements included things like, they came to the consensus that Ankyloglossia does not cause sleep apnea, nor does it typically affect speech. It may, as children get older, affect some of those mechanical social functions. And it may also be a potential contributor to difficulty in breastfeeding, particularly latching and particularly the development of pain in moms. However, many things can cause difficulty with latching, pain for moms during breastfeeding. So one of the caveats or cautions in these statements was that when suspected Ankyloglossia should be carefully evaluated by careful history, physical exam prior to recommending treatment. Again, you can read the full consensus statements. They include things like considerations for or contraindications to frenulotomy, and you can read those if interested. Number 6, prevention begins early. And this is a sort of hopping on to Dr. Chin's prevention as her number 1 talk. And just a message that we do recognize in primary care that prevention begins early, and optimal early prevention for kids really is care that happens prenatally, right? Prevention, the ultimate prevention in children happens in pregnancy when you have that time to both affect the oral health of moms and families, as well as the health of the pregnancy. We know that pregnancy itself, risk factor for things like gingivitis, things like periodontitis, which for the pregnancy are states of increased inflammation, certainly place that pregnancy at risk of things like preeclampsia, low birth weight, and preterm birth. And we all know that pregnancy is a time that everybody gets more interested, has heightened awareness and interest in healthy behavior. So great time to get moms in for good oral health. However, one of the things that interferes with this, and we see this a lot in primary care, is this prevailing attitude among the population that oral health care, oral dentistry may not be safe in pregnancy. We know that is, we know that that is not actually the case. In 2012, the expert work group meeting, the members, all they're listed in purple, convened for you in dentistry that probably know this guideline has been around for several years. We recognize this guideline in primary care and do our best certainly to continue to convey this message that oral care is safe. Oral care is definitely something that all pregnant patients want to participate in. And then finally, HEET to HEEONT. And what does this mean? As stated so well in an article published in 2015 by the American Journal of Public Health, it's the effort to put the mouth back in the head. And in primary care, obviously, HEENT, for those primary care providers who are listening, during an exam, we examine the head, eyes, ears, nose, and throat. What that really, when you stop to think about it, means is that we go from the nose right past the oral cavity, the back of the mouth, skipping the teeth. So there is definitely a renewed interest in, as I said, putting that oral cavity back in the mouth, in training in oral health, in primary care, both residencies, medical schools, PA programs, because we do recognize that the team approach to oral health is critical. We know that there's shortages both in dentistry, shortages in primary care, and that none of us can actually do this alone. We know that patients are more likely to adopt healthy behaviors if they're hearing the messages from both. And as Dr. Chin said previously, in primary care, we have the distinct pleasure to have early exposure both to pediatric patients as well as pregnant patients in their care, and we have the opportunity to make a difference. And so, again, as I said at the beginning, honor and privilege to participate in interprofessional efforts to achieve improved oral health for all our populations. I'll turn it back over to Tamana.
Thank you so much. I think we have a few questions, which I would like to take at this time. So our first question is, as dentists, what is expected of us if we see a child with autism? So, Dr. Chin, would you like to talk about that a little bit?
Sorry. So the question is, what is expected of dentists if
Yes.
a dentist identifies autism?
Yes.
So I think that it would be best to loop in the primary care provider and to just tell parents, hey, there are some findings that I think would be best communicated to your PCP. Would you mind if I gave them a call or wrote them a note just to tell you that I noticed, XYZ, and because your PCP may be interested and may want to follow up with you. I personally, as a dentist, would not want to make the diagnosis, but I would just want to pass along the information. And Denise, maybe you have other information about how you would like that situation to be handled.
Absolutely. Thanks, Catherine. Yeah, I, even as a primary care provider, I would not, as you say, diagnose autism, but I would do exactly as you say. I would encourage all our interprofessional team members, starting with primary care is an absolutely great way to start, sending us a note. And then what we would do is further talk with parents and get them referred for that complete developmental evaluation. And as a note to that, I think sometimes it's difficult to think about how do we bring this up to parents when we see something that we think may be concerning. I think over the years, I have found that the approach of straightforward honesty is very helpful, because most of the time parents already know it. Parents already suspect it. They're already worried. And the fact that you will be upfront with them and honest and say, you know, I share this concern, oftentimes is more of a relief to families. So yeah, I think addressing it, primary care is certainly willing to help.
Thank you so much for that. I think we have another question. If primary care and dentistry applies fluoride to children's teeth, is there a recommendation of minimum interval between the applications? And should I not apply fluoride if it has already been applied by the dental in the last several months?
Great question. I think it really depends on how current the patient is with their dental home. So if they are keeping their 6-month checkups, then I don't think that primary care needs to be placing the varnish at all, because that dentist has done caries risk assessment and determined how often that patient needs to have the fluoride treatment. I think if it's been a couple of years since the patient has gone in to see the dentist, which is pretty common, especially with a pandemic, then go ahead and apply and just let the parents know that they should let their dentist know during their next dental checkup. So we typically apply it every 6 months for our patients with high caries risk. If we have a very, very motivated family who wants to come in for extra oral hygiene instruction, and we're seeing a lot of lesions, that caries lesions that we are trying to control, then we may place it every 3 months.
Okay. Can I ask a question for you, Catherine? This is Denise. So if we would have a family who would say, yeah, you know, my dentist, I did that at the dentist. I can't remember how long ago that was. Is there a danger in applying fluoride at a more frequent interval if, for example, we didn't know?
No, there isn't.
Yeah, thank you. I think we have one question, and that talks about, Lexi's asking, can you both talk about the differences in recommendations in the length of breastfeeding? What's the AAPD's view and what's the AAP's view?
Sure. So, you know, basically the difference, I think, is based on, you know, the dental findings. But for me, if a patient is going to continue breastfeeding, the main thing is that they clean their teeth afterwards. There's no problem with breastfeeding. It's just sleeping with the milk around the mouth. And so if they're breastfeeding and then the child stops, is awake, plays, has their teeth cleaned, then, and, you know, the pediatrician feels that that is a good source of nutrition for the patient, then I think it's fine to continue on with that, as long as they're cleaning the teeth. It's the problem where children are feeding throughout the night and that milk is sitting on the teeth for for hours at a time. That's where we see kids get into trouble.
I think from the standpoint of primary care, I can answer the question. The AAP recommends primary breastfeeding for 6 months. But having said that, any breastfeeding is better than no breastfeeding. So certainly we encourage mothers to consider and start with breastfeeding. We do all that we can to encourage that for as long as the family is able to do that, and as long as that can be worked into their lifestyle. So yeah.
All right, we have 5 minutes remaining, and I wanted to make sure we have answered everyone's question. If you have another question, please feel free to unmute and ask, or you can put it in your chat. I also see that Dr. Callanan has added the Qualtrics link in the chat. She's done it again. If you would like to get CE, dental CE, please make sure that you click on the link and complete the survey so we know that you have done that, and then we will forward you your CE certificate. At this point, I would like to ask again if there is any other question from anyone. And I would also like to thank both Denise and Katherine for taking out time from their very busy schedule and talking to us about pediatric primary care from both a medical perspective and a dental perspective. Thank you so much both for coming in and talking to us. And as a reminder again, for those who joined a little bit later, we will have a fall session on 7 things where we will have Dr. Susan Somerset here from the dental school and Dr. Liza Claus from the School of Pharmacy, who will talk about clinical pharmacy as well as dentistry. I see something coming in. Oh, thank you very much. We have thanks coming in for both Denise and Katherine. With that, I would like to close today's talk. I know some people have to run back to clinic. Thank you very much, everyone, and we will see you in the fall back with 7 things.